name is Dr. Lucy Mungai. My name is Dr. Mungai. I'm the one who has the honor of introducing Dr. Debbie Matthews. Dr. Debbie Matthews is in Nairobi because he's our external examiner in pediatric and adolescent endocrinology fellowship program. She's also, at the moment, the external tutor for the last 1 week and the next 1 week, where he's taking our fellows in pediatric endocrinology intensive training until next week on Friday. So as an introduction for Debbie. Debbie Matthews has been a consultant pediatric endocrinology and diabetes at the Great North Children's Hospital in Newcastle upon Tyne since 1999. Debbie trained in medicine in Cambridge and King's College Hospital, London, and held junior posts in London and Oxford before moving to Newcastle, where she completed her postgraduate clinical and research training. Debbie has special interest in Turner syndrome, primary ovarian insufficiency in adolescents, and in late effects of cancer treatment, including bone marrow transplantation. She has run a holistic region service for girls and adolescents with Turner syndrome and a multi-professional clinic for long-term survivors of bone marrow transplant for 20 years. Over the last 5 years, Debbie and her colleagues in adolescent gynecology have established a joint adolescent and endocrine gynecology service. She's a member of the steering committee of the European Society for Pediatric Endocrinology Turner Syndrome working group and is one of the UK clinical leads for the newly established Turner Syndrome platform and the Disorder of Sex Development Registry. She was a committee member of the British Society of Pediatric and Adolescent Gynecologists from 2019 to 2023. Debbie is one of the working group members to revise the international guidelines for the management of Turner syndrome due to be published in 2024. Welcome, Debbie. Thank you.
Okay, thank you very much. It's lovely to be here. I'm going to start by sharing my screen. This will stop others screen sharing, yes. And then I want entire screen. So I need to just find my presentation. Can everybody see that? Can everybody hear me?
Not yet.
Not yet.
Yes.
I can hear you. No, can you not hear me?
I can hear you.
You can. Can everybody else hear me?
We can see you.
Yeah, okay. So I'm going to talk about the late endocrine effects of treatment for cancer, including bone marrow transplantation.
We can't see the slides.
Sorry?
We cannot see the slides.
You can't see the slides? Well, you should be able to. Let me come back to... So the site will be able to see the contents of your screen. So I'd like to thank you very much for inviting me to give this talk and for the introduction. My name is Debbie Matthews, Dr. Matthews, and I come from the far northeast of England in Newcastle upon Tyne, which has a population of about 300,000. There's approaching 1 million in the wider conurbation, and secondary and tertiary paediatric care are provided by the hospital shown on the right, which is the Newcastle Hospital's NHS Foundation Trust, based at Great North Children's Hospital. And I'm going to talk about the late effects of treatment for cancer in children and adolescents. The survival of childhood survivors with cancer has improved over the last 50 years, so that now 5-year survival rates exceed 80% in Europe and USA. In the 5-year survival rates are about 50% in Nairobi, under 45% in Harare and Kampala for the most common cancers, as reported in the International Journal of Cancer in 2018. But with this number of survivors, we've got long-term side effects of both chemotherapy and radiotherapy are becoming increasingly apparent. And this slide here really just shows us, sorry, I'm just going to hide the systems affected by treatment for cancer in children and young people. You can see that a wide range of systems are affected. And if you run your eye down, you can see that the RT, the radiotherapy, features everywhere. So endocrine is probably the system most commonly affected by radiotherapy, surgery, and alkylating agents, such as cyclophosphamide. Cardiovascular system, radiotherapy, and anthracyclines, which cause dilated cardiomyopathy in some patients. Respiratory system, radiotherapy again, and other agents such as busulfan, which can cause a fibrosis within the lungs. Hepatobiliary system, radiotherapy, methotrexate, mercaptopurine, and importantly, iron overload for those who've received multiple transfusions as part of their cancer treatment. Renal, radiotherapy, isophosphamide, which causes a significant hemorrhagic cystitis, and also cisplatin. Metabolic, radiotherapy. Auditory, radiotherapy and cisplatin, both of which can impair hearing or cause deafness. Eyes, radiotherapy with the production of cataracts. And neuropsychological, once again with radiotherapy and intrathecal chemotherapy. And one of the most important late effects of cancer treatment is, sorry, I've got a thing here which I can't see, but the least important effect is second cancers, which are most commonly related to radiotherapy and alkylating agents. Now, there are important sequelae arising from this knowledge of these late morbidities related to cancer treatment. And the first of these is that knowledge of the late effects has helped to stimulate the development of new cancer therapies, proton therapy, immunotherapy, and molecular targeted therapy. But what we don't know yet is the short and long-term adverse effects of these agents, and this is now being explored. Secondly, these morbidities has really highlighted the need to develop a clinical service for the long-term follow-up for survivors of childhood cancer. And this one is just an example to show you about proton beam therapy, which is a new type of radiotherapy. So in conventional radiotherapy, shown in the patient on the left, the deposits of the radiation is deposited most of its energy before it's even reached its target. On the other hand, targeted proton therapy deposits most of its energy directly on the target. So there's much less scatter to normal tissues. And this slide at the bottom shows a proton beam generator. Until very recently, we didn't have one in the UK, and patients needing proton beam therapy were treated in the US. We do now have one, but only one in London. So the next stage is, what are we going to do to develop a surveillance clinic for childhood cancer survivors? First of all, we need an administrative team, an up-to-date registry of children and young people treated for cancer, including their treatment summary with doses. And I understand from my discussions with Dr. Thomas Nigwiri from Gertrude Children's Hospital that this is not too far away for Kenya, which is excellent. We need the administrator to contact patients needing review. And very importantly, because this may seem like a very daunting task, not all patients at all require long-term clinical review. We also need the clinical team who are going to be coordinated by the paediatric oncologist. And this photograph is of my colleague, Professor Rod Skinner, who has been at the forefront of the development of the surveillance of late effects globally. And I've had the privilege of working with Rod for the past 20 years in a joint bone marrow transplant endocrine clinic. So who are we going to have in our clinical team? We would have a paediatric oncologist with an interest in late effects of cancer in children and young people, who'll be the main coordinator of the service. And here they need to identify those needing long-term surveillance and to design an individualized, suitable follow-up plan, and to carry out the primary screening in their general follow-up clinics, hopefully with a clinical nurse specialist to organize and coordinate patient clinic review. Next in line is the paediatric endocrinologist, ideally working with the oncologist. And then the paediatric oncologist is going to make referrals to doctors in cardiology, respiratory medicine, who are familiar with the management of the late effects. Really very important, but not always readily available, a social worker, and to ensure the investigations that we need, such as lung function testing, cardiac screening, echocardiograms, are readily available. So moving on then to talk about the late endocrine effects of treatment for cancer in children and adolescents. Endocrine complications are highly prevalent, and about 50% of survivors experience at least one endocrine disorder over their lifetime. But there's a variable latency, so they may develop their endocrinopathy within a year of finishing treatment, or it may be 20 years or even 30 years. We're finding that these can arise very far down the line. And what about the risk factors for endocrinopathies? Well, these primarily include radiotherapy, particularly to the head, the neck, or pelvis. And this includes total body irradiation, or TBI, used in hematopoietic stem cell transplantation or bone marrow transplantation, BMT. And treatment with chemotherapy, particularly alkylating agents, are highly gonadotoxic. And finally, many of these individuals may have prolonged courses of steroids, which can render them with adrenal suppression. So what about the common parts of our endocrine system which are affected? We get hypothalamic pituitary axis dysfunction, primary thyroid dysfunction, primary gonadal insufficiency. Many survivors suffer with low bone mineral density, obesity, and may have adrenal suppression. More common following TBI or bone marrow transplant is diabetes, mainly type 2, and perhaps a full-blown metabolic syndrome. And what has been happening really over the last 10, 15, 20 years even, is that experts from around the globe have put together international evidence-based or expert consensus-led guidelines. And these guidelines are very readily available. And as I say, we don't have the evidence base for everything, but because these experts are so experienced in managing young people with cancer and their late effects, then they can develop appropriate and helpful guidelines. And these are helping to improve outcomes by prompt diagnosis and treatment of endocrinopathies. And they're particularly important when we're addressing some complex multimodality treatments that some of these children and young people undergo. And just showing here at the bottom, we've got a couple of articles, one from the International Late Effects of Childhood Cancer Guideline Harmonization Group for the recommendations for premature ovarian insufficiency surveillance, and another one from the same group for gonadotoxicity surveillance in the male. So I'm going to start really with just a very brief and fairly straightforward case history for Sally. So she was a normal baby, and she was diagnosed with acute myeloid leukemia age 1 year, treated with chemotherapy, including anthracyclines. Her AML relapsed at the age of 2 years of age, and she was treated with an unrelated donor allogeneic bone marrow transplant at 2.5 years. She received conditioning with 120 milligrams per kilo of cyclophosphamide, so a large dose, and total body irradiation, 14.4 gray in 14 fractions. So that's every part of your body is irradiated, and had follow-up with the bone marrow transplant team. So just thinking of her, what are her risks? So for endocrine late effects, not thinking of her cardiac ones, so she's had anthracycline, she's at risk of cardiomyopathy, but simply from her conditioning from her bone marrow transplant, the TBI gives her a moderate risk for primary ovarian insufficiency, similarly for primary thyroid dysfunction, and a moderate to low risk for growth hormone deficiency. Treatment with cyclophosphamide high dose gives her a high risk for primary ovarian insufficiency. So by now we've got high risk for primary ovarian insufficiency and a moderate risk for primary thyroid dysfunction and a rather smaller risk for growth hormone deficiency. So how are we going to plan surveillance for her? Well, height, weight, height, velocity every 6 months. Has she got symptoms of thyroid dysfunction? Has she got a goiter? And measuring thyroid TSH and free T4 annually. Looking at pubertal development, looking at LH and FSH from 10 years, and examining her for signs of onset of puberty. And Sally was actually referred to our team at the age of 11 with short stature, slow growth, and biochemical signs of primary ovarian insufficiency with a markedly elevated FSH. And what we did, we confirmed what was going on. So slow growth was confirmed on her growth chart. She had a normal IGF-1. She underwent a glucagon provocation test looking for growth hormone insufficiency, which gave a borderline result. Since her parents were not particularly keen for her to be treated with growth hormone because of everything she'd been through, she went on to have an insulin stress test to see if she was truly growth hormone sufficient or otherwise. But her maximum growth hormone on that was very low. And since this is our gold standard test, she was started on growth hormone treatment. She had strong biochemical signs of primary ovarian insufficiency, no signs of puberty. She was keen to start and was started on very low dose transdermal 17-beta estradiol. She had normal thyroid function. And this is her growth chart from the age of 11 years. She'd been started on growth hormone. She was on the 0.4 centile at the time the growth hormone was started. And I think what you can see is she grew very poorly and did not have a good growth hormone, a good growth, pubertal growth spurt. And this is because radiotherapy, TBI, is very bad for your growing bones. And she received her TBI at a very young age. So her final height is low, but she is truly growth hormone deficient and was retested as an adult, and this was confirmed. So moving on then to the hypothalamic pituitary axis dysfunction following treatment. So what are the risk factors here? Well, radiotherapy, a really high risk for HPA dysfunction. But there are different radiosensitivities for each anterior pituitary hormone. Growth hormone is the most sensitive. To radiotherapy, greater than 18 gray may render you growth hormone insufficient. They gradually become more and more radio resistant until we get to ACTH, where you need radiotherapy to the anterior pituitary of about 30 gray before you become ACTH deficient. And this is very good, obviously, because you can, being adrenally insufficient is a life-threatening condition. And by fractionating the radiotherapy dose, so instead of giving it all in one go, it's broken into 14 sessions. That helps to reduce some of these late sequelae. Other risks, there's a minimal effect of chemotherapy on HPA function, but the effect of local tumor growth and its surgery really has a very important effect, but this is early rather than late and includes diabetes insipidus, which I'm not really going to be covering in this presentation. So how are we going to carry out surveillance for the hypothalamic pituitary axis? Well, we're strongly worried, aren't we, that we could be developing growth hormone deficiency. So height, weight, if we can, a sitting height, and a height velocity every 6 months. And if they're growing poorly, to consider dynamic anterior pituitary testing. TSH and free T4 with IGF-1 annually, and reviewing for ACTH deficiency. So many will put forward the idea of doing an early morning cortisol, but there are many, this is not a particularly sensitive or specific measure and can give both false positives and negatives. So in our clinic, we tend to do synaptin tests probably every 5 years in those with some risk. If it's a higher risk, we may do them more frequently. Again, we will ask for symptoms. And then LH, FSH, estradiol or testosterone from the age of 10. Close monitoring for both precocious or delayed puberty, and keeping a close watch on pubertal progress until it's completed. Treatment, I'm not going to talk about these in any detail because for most of these patients, the treatment is no different from other individuals with other underlying conditions. So somebody with growth hormone deficiency, because their growth hormone deficiency, they're growth hormone deficient, they haven't had radiotherapy. But I have highlighted in red or green particular practice points that we need to consider in childhood cancer survivors. But we do know that growth hormone is given by injection, either daily or now there are weekly or even monthly preparations, but it's expensive. And conditions for storage, it needs to be kept in the fridge, may be difficult for some families. It benefits you by increasing your final height and your growth, and also has important effects on bone mineral density, cardiovascular health, and metabolic health. But potential harms in this group is it's only very low quality evidence, but has been implicated in the occurrence of secondary neoplasms in survivors. Now, this is already a group who are at risk of second cancers. They've already had one, they're more at risk of two, and they've had a lot of treatment, but still this is something that needs to be kept under close review. Thyroxine. In this scenario, all right, we're talking of secondary hypothyroidism. So we can more or less ignore the values of TSH, but we're aiming for a free T4 in the mid to upper normal range. Potential harms of starting thyroxine is if that patient has ACTH deficient, by starting thyroxine before you've addressed the ACTA deficiency can precipitate an adrenal crisis. And this is because treatment with thyroxine in a hypothyroid, ACTH deficient patient allows increased clearance of cortisol. So effectively, you have even less cortisol around and you precipitate an adrenal crisis. So we would need to test this first. But remember that ACTH deficiency really only comes when you've received a lot of radiotherapy to the anterior pituitary, usually more than 30 gray. What about LH and FSH, so gonadotrophins? We don't replace them generally directly. They're replaced as estrogen for girls, testosterone for boys. But unfortunately, in many countries, they're not readily available in the low doses required to induce puberty. For those patients wanting fertility, estrogen and testosterone isn't going to be helpful. And that's when we need to use gonadotrophins, and it becomes a much more complex regimen. But using estrogen, testosterone, we can have normal pubertal development, maintenance of secondary sexual characteristics, effects on bone mineral density, quality of life, final height, and potential harms really is if it doesn't work very well. Finally, ACTH, we're replacing this as hydrocortisone. We don't need to treat with aldosterone because it isn't under ACTH control. Standard dose replacement, 6 to 8 milligrams per meter squared per day in 3 divided doses. And I've put here that they still need advice, despite the fact this is ACTH deficiency, for stress doses for illness, and hydrocortisone for injection for emergencies. Potential harms, avoiding over-treatment because that can lead to a Cushingoid state. And then the final one really is central precocious puberty. So rather different from the others. This is just puberty obviously occurring early, and that's related to rather lower doses of radiotherapy and the presence of hydrocephalus. And it's very easily missed. So it's important to ensure pubertal assessments carried out every 4 to 6 months, and particularly important in those who are growth hormone deficient, who may just have, this may occur with radiotherapy doses of around 18 to 20 gray. So they've got central precocious puberty. They've also got growth hormone deficiency, but they're growing at a satisfactory prepubertal rate when really they should be growing at a pubertal rate. So this will be treated if it arises with the central precocious puberty, that is, with GnRH analogues until the child is old enough to progress further through puberty. So that's the hypothalamic pituitary axis. What about primary thyroid gland dysfunction? Well, this is one of the most frequent late effects, and hypothyroidism occurs in about 14 to 21% of all childhood cancer survivors. And thyroid tumours form 10% of all second cancers. Hypothyroidism with thyroidism may also occur. What are the risks? Not surprisingly, we've got radiotherapy, so Paclitaxel radiation for Hodgkin's lymphoma, craniospinal radiotherapy for medulloblastoma, treatment with MIBG, which uses radioactive iodine for conditions such as neuroblastoma, and those receiving total body irradiation. Chemotherapy may also have an effect, so a mild effect perhaps of cyclophosphamide, but the TKIs, the tyrosine kinase inhibitors, which are some of the newer chemotherapeutic agents such as sorafenib, imatinib, they also affect thyroid function, although the mechanism is uncertain. And TKIs are used to inhibit tyrosine kinase, which is produced by which is encoded by the BCR-ABL gene found in chronic myeloid leukemia. And we can also find thyroid dysfunctional post bone marrow transplant, because this may be due to transfer of the autoimmunity tendency from the donor, or sometimes adverse effect of some of the immune system modulators. So knowing that we could have primary thyroid dysfunction, how are we going to carry out surveillance? Well, we can do this annually. Have they got symptoms of either hyper or hypothyroidism? To counsel patients that they are at an increased risk of thyroid cancer. The benefit of having a thyroid cancer is your thyroid gland sits at the front of your neck. It's very easily observed, and palpation of the thyroid gland once a year for nodules is important. Ultrasound, possibly if there are concerns, but ultrasound gives rise to a number of false positives. Measuring TSH and free T4, and if there's evidence of hyperthyroidism with an elevated free T4 and a suppressed TSH, to consider looking at free T3, ATPO, and TBI antibodies, so that you can see if you are dealing with a significant Graves' disease or perhaps a more subtle autoimmune hashitoxicosis. So how are we going to treat? Well, once again, in red, we've got evaluation of adrenal axis in those also at risk of adrenal insufficiency. To use levothyroxine in standard doses, as you would for anybody with hypothyroidism. But the group with compensated hypothyroidism, elevated TSH, perhaps 10, but with a normal free T4, we would also treat them, which you may not do in somebody with another underlying diagnosis. And this is because we don't really know what the effect of an elevated TSH on the growth, further development of thyroid nodules might be. So we'll come back to this a little bit later when I share with you some of our bone marrow transplant data. But despite the fact that we would treat compensated hypothyroidism, we're not trying to aim for a suppressed TSH. It's fine to keep it in the lower part of the normal range. Trying to suppress TSH can render individuals feeling less well because you can end up with rather high free T4 levels. And hyperthyroidism, if it arises, much less commonly, but managed in the usual way, recognizing that it may be transient because of transfer of autoantibodies from the donor. And therefore, if you're choosing how you're going to manage this, dose titration with carbimazole rather than a block and replace regime will allow you to see if that hyperthyroidism is resolving. And this is just some of our outcomes from our survivors of bone marrow transplantation for cancer in Newcastle. And this is 35 young people, 19 males, 16 females. And this is not all our patients, but these had the same conditioning. Most had different forms of leukemia, so 15 ALL, 8 AML, 6 CML, and 5 other rarer types of leukemia. The mean age at their original diagnosis of their leukemia was 7.7 years, with a mean age of bone marrow transplant at 10.1 years. And these patients have been followed up by us for 19.7 years, with a range of 16 to 23.5 years. And all patients received the same conditioning with high-dose cyclophosphamide and TBI 14.4 gray. And from them, 14 patients, or 40%, developed thyroid dysfunction, 5 with just subclinical hypothyroidism, 8 with frank hypothyroidism, 1 with thyrotoxicosis. 5 patients, 14.3% of them, developed thyroid cancer, 3 papillary cancers after a median of about 14 years from transplant, 2 follicular cancers after 16.7 and 21 years, and all these cancers were incidental findings. So found for other reasons, usually they were having a scan for some other purpose. 1 patient developed a follicular adenoma, so a non-malignant lesion, 9 years after bone marrow transplant, and 2 patients had silent nodules identified on image, and they are just being observed. Moving on then to primary gonadal insufficiency following treatment in childhood cancer survivors. And this really affects both males and females. And what's gonadotoxic? Radiotherapy, particularly in males. So just 2.5 to 4 gray abolishes spermatogenesis. In girls, they have rather more radio resistance, and 20 to 30 gray of abdominal radiotherapy would give a high rate of ovarian insufficiency, but smaller doses, they should be okay. Chemotherapy, especially alkylating agents, cyclophosphamide, busulfan, possibly transient, but usually long-term. And then we have the effects of the neurobiological agents, such as TKI, which we don't know. And whenever we're doing surgery, gonads are very sensitive to damage. So thinking first about primary testicular insufficiency in males, so impaired spermatogenesis, first of all. So these are 2 different separate processes occurring in males. So in prepubertal boys, the testes are particularly vulnerable to radiotherapy, and anything more than 2 gray prevents later spermatogenesis. Adult men are a little bit more radio resistant with 2.5 to 4 gray. And treatment with alkylating agents, cyclophosphamide, procarbazine, and ifosfamide are also important. What are we going to do at surveillance? Well, really at the time that they had their diagnosis and their treatment, we need to be counselling about their risk of impaired spermatogenesis and the implications for their long-term fertility. Once they've finished treatment, they're under surveillance. Really, we'd only carry out investigations at that patient's request. So they want to know whether they're infertile or fertile. And in that case, the initial monitoring would be to look at testicular volume. So most testicular volume is going to be made up of seminiferous tubules. So if they're not present, then we can assume that spermatogenesis will be impaired. FSH, which will be elevated if they've got impaired spermatogenesis, and inhibin B, which will be depressed. And if it's appropriate, we may then proceed to semen analysis. This isn't very good news for long-term fertility in males. So what preventative measures may we look at? Well, shielding testes from the radiotherapy. There's very little evidence that that's effective. What about suppressing hormones with GnRH analogues? Again, there's no good evidence that works. What about treatment? What can we do to help to preserve fertility? Well, post-puberty, cryopreservation of semen can be carried out and can be stored for many years. What about pre-puberty? They're not producing any sperm at all or any immature. They just have germ cells. So really all that can be offered is cryopreservation of testicular tissue, but really we haven't made huge progress with that so far, so only as part of research or clinical trial in a recognised centre. What about testosterone deficiency? Well, the Leydig cells, which are producing testosterone as opposed to germ cells, are much more resistant to radiotherapy. So it takes radiotherapy greater than 12 Gray or total body irradiation to give rise to an increased risk of testosterone deficiency. Treatment with alkylating agents will also increase that risk. And how these individuals present depends on the age at onset. So if it's around the time of puberty, they may have delayed puberty or arrested pubertal development. Post-puberty, and don't forget, these can be lads of 12, 13, 14, reduced sexual function, fatigue, a reduction in body hair, and a reduction in lean body muscle. So they're less strong. They're aware that they're weaker than they once were. How are we going to carry out surveillance? Well, in pre or peripubertal boys, growth in height, height velocity, pubertal development, pubertal progression with Tanner staging, early morning testosterone with LH, and to refer if there's no sign of puberty by 14 years or they have signs of pubertal arrest. Post-puberty, asking about symptoms, but really fairly low-key surveillance and annual early morning testosterone with an LH in those at high risk of testosterone deficiency. How are we going to manage it? Well, in those starting puberty, we would start testosterone treatment at 11 to 12 years of age. We can use intramuscular, oral, or transdermal forms and start with a low dose, perhaps a 1/7 to a 1/10 of the adult dose, and increase the dose gradually about every 6 months according to response. And we can monitor this by their clinical response and also by their biochemistry, looking for early morning testosterone to be within the normal adult range. What about management of testosterone treatment in post-puberty? Well, then we've got both intramuscular and transdermal forms, and we can monitor that with testosterone levels together with a full blood count and hematocrit. And hematocrit, very important to making sure that we don't overdo the replacement, because that can be deleterious to health as well as insufficiency. What about for the females? Primary ovarian insufficiency. Well, treatment with alkylating agents, as you increase the dose, the risk of POI seems to increase, as does the risk with dose of radiotherapy. And if we have a combination of radiotherapy and alkylating agents, that's especially gonadotrophic. Clinical presentation depends on the age at onset in just the same way as it does for males. So delayed or arrested pubertal development. Post-puberty, we've got marked effects on bone mineral density, an increased risk of ischemic heart disease, reduction in sexual function, lean body mass, and quality of life. So a big positive drive really to make sure that we're replacing sex steroids in these sex steroid deficient individuals. And this here shows the risk of ovarian insufficiency with the dose of radiotherapy according to age. So along the x-axis, we've got age in years from 0 up to 50. And on the y-axis, we've got dose in grey of radiotherapy from 0 to 20. And you can see here that if you're 2 years of age, you need to have about 19 gray of radiotherapy to your ovaries to render you infertile. However, by the time you get to 15 or say 20, you know that's reduced to about 15 gray. And then there's a rapid deceleration from your late 20s into your early 30s until obviously it's not radiotherapy that's doing it. You are naturally coming to the end of your reproductive life. So how are we going to carry out surveillance? Well, counselling, again, about the risk of this with treatment, the implications for fertility. And what, again, is really important is that even if these females go through puberty, they start to menstruate as they should do, they are still at risk of a premature menopause. So they may have a menopause not at 50, but in their 20s or 30s. And usually you stop being fertile about 10 years before you reach menopause. And therefore the advice to them would be, if you want to have a family, not to delay it any longer than is needed, that you should move quite quickly. Pre and peripubertal, monitoring growth in height, Tanner staging, very similar to our males, referring if there's pubertal arrest or no signs of puberty by 13. Post-puberty menstrual history, very important, FSH and estradiol, and to refer if the menstrual dysfunction suggestive of POI. So, for example, they have secondary amenorrhea. So how are we going to manage? So girls who haven't gone through puberty, we would start with 1/10 of the adult replacement dose at around 11 to 12 years of age. And natural 17-beta estradiol is preferred, but ethanol estradiol can be used in low doses, and increasing the dose every 6 months according to clinical response. And then after about 2 years, we're adding in a cyclical progestogen for about 14 days every 1 to 3 months. And what that does is to induce endometrial shedding, i.e. these girls will start to menstruate, but it also protects, and the main reason for giving it is it protects against endometrial hyperplasia and its sequelae, endometrial carcinoma. What about post-pubertal females? Remembering that they can be as young as 10 years old, so they're likely to still be in the paediatric service. So again, we prefer natural physiological 17-beta estradiol, but ethanol estradiol is also perfectly acceptable. Progestogen, natural progesterone, micronized progesterone is preferred, but there are a number of different progestogens, dydrogesterone, medroxyprogesterone, levonorgestrel, and norethindrone, all of which can be used depending on what you have available in your setting. HRT preparations designed for women who've reached their menopause and are having menopausal symptoms, those preparations are preferred for hormone replacement in young adult women, but you can also use the combined oral contraceptive pill. Why this is in green is that there is some increased risk of the pill in cancer survivors who are already at risk, increased risk of thromboembolic disease and hypertension, which is an additional risk with using the combined pill. But still the benefits outweigh the risk in most cases. And if you're taking the combined pill, you would take it continuously, not for 3 weeks out of 4, with a break for 3 to 5 days for breakthrough bleeding. Or perhaps you might want to take 3 packs back to back and then just have an elective break for 3 to 5 days. What about fertility preservation in females? Once again, counselling at diagnosis regarding infertility and options for fertility preservation. Shared decision-making, this is a really complex area. If these girls are post-puberty, it's possible to stimulate ovaries to allow oocyte harvesting, which can then be cryopreserved, or if that individual has a partner, IVF and then cryopreservation of embryos. That's not really paediatrics, but I think important for people to know what is available. Pre-puberty, surgery to remove one ovary for cryopreservation. Then when fertility is desired many years later, replacing strips of ovary in the pouch of Douglas. So very crude, but more than 100 babies, really quite a lot more than 100, have been born worldwide using this method. Oophoropexy, where you transplant the ovaries to another site so they're not going to be affected by local radiotherapy, also possible, but ovaries don't like being moved around. So really minimal evidence of success. And again, hormone suppression with GnRH analog, really in a research setting only. And one of the downsides of this is that if the girl and her family decide that they want to pursue one of these options, you're looking at either stimulating ovaries, carrying out surgery, when these young people would be starting their treatment for cancer. So does that delay in starting treatment impair their chances of long-term survival? So this is really why it's a very complex area. But for infertility is so important for childhood cancer survivors that there are a lot of steps to try and carry out fertility preservation if possible. So some outcomes from our audit of our survivors for bone marrow transplant. We had 19 males, and at their last follow-up, 10 had testosterone deficiency. 9 of whom were being treated with testosterone. The other one had stopped treatment since they developed carcinoma of the breast. And 1 who had assisted parenthood, so taking an immature spermatid really and using ICSI, or not really immature spermatozoa, but using ICSI, so intracytoplasmic injection of the sperm into the egg as an IVF procedure. 16 females in the study, all right. All 16 had biochemical evidence of ovarian insufficiency, so elevated gonadotrophins, and 12 of these have required estrogen and progestogen replacement. But in 3 patients, there have been 8 pregnancies, despite them having some ovarian insufficiency, and there have been 2 live offspring. So not hugely successful, but certainly 2 live offspring have been born. Moving on then to type 2 diabetes and obesity following treatment for cancer. So we've got a number of risk factors for obesity and type 2 cancer: hypothalamic injury, tumor, surgery, or radiotherapy can cause complete disruption with the leptin pathway, satiety center. So these individuals no longer feel satisfied when they've eaten, and they will eat and eat and eat and eat. And so very difficult to manage. Childhood acute lymphoblastic leukemia. At one time, we treated them electively with cranial radiotherapy. So 18 Gray was given routinely, but because we realized the adverse effects of radiotherapy, a trial was done to see if that could be withheld, and this was successful. So generally, they're not treated with cranial radiotherapy unless they've got CNS effects of their lymphoblastic leukemia. High-dose steroids is also frequently used in treatment, and up to 46% of these patients are obese at 10 years follow-up. So this is quite remarkable. Those who've undergone bone marrow transplant, both the TBI, so a reduction in lean body mass, and central adiposity, not necessarily full-blown adiposity, and abdominal radiotherapy important in type 2 diabetes because of the effects on the pancreatic beta cells. What about metabolic syndrome? So that's type 2 diabetes, hypertension, hyperlipidemia. And what we find is that affects about 32% of cancer survivors, compared with 18.3% of the general population under the age of 40. So this is, practically doubling this. So very important, and this is multifactorial. So it may be partly treatment related, but also when you look at these individuals and you look at the lifestyles they're having, they're generally much less active than their healthy peers. And metabolic syndrome, independent of obesity, is a particular problem in survivors of bone marrow transplant. So what are we going to do here? We're going to do annual height, weight, and BMI measurements, a fasting blood glucose or an HbA1c every 1 to 2 years, and keeping an eye on blood pressure. And how are we going to manage them? Encourage exercise, encourage healthy diet, and we can also use GLP-1 receptor agonists. So these are long-acting glucagon like peptide. So by giving a receptor agonist, you're actually going to block these, and so you're reducing glucagon effect, and that includes things like liraglutide and semaglutide. Bariatric surgery has certainly been tried in those with hypothalamic obesity when the secondary morbidities relating to their obesity becomes apparent, and otherwise management of type 2 diabetes in the usual way. And this just shows the GLP analogues. You might expect weight loss of 7 to 15% over a year plus. And side effects are mainly gastrointestinal, and these agents need to be given by injection. Bariatric surgery, a number of different procedures. There's a gastric sleeve, gastric bypass, gastric band. They're very rarely used in children, but a BMI greater than 40 or a serious underlying condition with a BMI 35 to 40 may possibly be an indication, but this is associated with a number of very unpleasant complications. So an average loss of 50 to 70% of excess weight over 3 years. Some manage to regain weight, but this is at the expense of them just not being able to eat properly. So they need to watch their diet very carefully. They can no longer just go out and have a pizza, for example. But there is improvement in glycemic control in type 2 diabetes. But because quality of life probably is compromised by these limitations, there's an increase in alcohol and substance misuse and an increase in suicide rates. So not to be considered lightly. What about outcomes from our survivors? Well, 10 out of 35 patients developed cancer, had cancer, developed diabetes at a median time of about 10 years, from 3 to 11.5 years post bone marrow transplant. 8 patients with type 2, 2 patients had type 1, and all of these are on oral hypoglycemic agents, plus or minus insulin at their last follow-up. And importantly, for our survivors, only 2 patients had a BMI over 30, i.e. obese, and very few with a BMI between 25 and 30. So the etiology here in this group is not their obesity driving it. And I just thought I would share with you the second cancers in our BMT survivors, just because this is probably the most obvious place to put it. But of that 35, we've had 11 new cancers in 10 patients, 4 thyroid, 2 sarcomas, 1 breast cancer in male, 1 bowel cancer, 2 less important or less serious squamous cell skin carcinomas, 1 squamous cell of the tragus, 1 benign thyroid adenoma. And there have been 3 deaths in the group, 2 who had the sarcomas, and 1 likely immune-mediated. This was a patient who was long-term follow-up was in Israel. She was one who'd had a live-born baby, and really following that, she seemed to have some unusual immune-mediated problem, which sadly led to her demise. And then there was 1 very late relapse, 8 years after finishing treatment, in a girl with acute myeloid leukemia. What about low bone mineral density? Prevalence reported as 9 to 18% of survivors, higher risk in survivors of ALL, CNS tumors, and bone marrow transplants. Really multifactorial. So there can be a direct effect of the cancer on the skeleton, such as with acute lymphoblastic leukemia. Treatment with glucocorticoids isn't good for your bone mineral density. Osteotoxic chemotherapy and radiotherapy. And then these treatment-induced endocrine deficits, such as growth hormone deficiency, hypogonadism. And then finally, malnutrition, physical impairment, and reduced muscle strength. And really, the adverse skeletal outcomes have also been recently described in children and young people treated with retinoids and the TKIs, such as imatinib, but they really have not been well documented. How are we going to survey them? Well, the recommendation is to carry out dual energy X-ray absorptiometry or DEXA scan. Really what we want to know is, are these patients fracturing? I mean, we do carry out certainly DEXA scans until they've reached their peak bone mass, so every 2 to 5 years. But really the emphasis on fracture history, but including crush fractures of the spine, don't forget that, and bone mineral density changes over time. So once you've reached your peak bone mass, then really things should plateau, and you don't need DEXA scan nearly so frequently. And what about management? Well, prompt recognition and treatment of any endocrine deficiencies, optimal intake of vitamin D and calcium, encourage exercise. Exercise is brilliant for improving bone mineral density. And as I've said before, these individuals are not very active. And for patients with low trauma fractures, consider the use of bisphosphonates to strengthen bones. They sit in the bone and strengthen them. Neuropsychological sequelae. So with all of this, you're probably thinking, these survivors, how are they going to possibly live a normal life? And what we really need to do is balance the risks of surveillance to the benefit of these survivors, of these continuing surveillance. So these survivors may continue surveillance to be a burden, an obstacle to having a normal life. But on the other hand, it may be reassuring for them to remain under occasional follow-up. It should be low-key, every 6 months before puberty, then annually, probably then 2 yearly, 5 yearly, or encourage them then, once they're in that system, to contact the team if they have any symptoms. And remember that this is on the background of numerous psychological sequelae in these survivors. Many of them have got poor self-esteem. They've got problems with relationships, employment, body image, lack of exercise. And again, I put in green, really coming to terms with infertility, and also quality of life is less good than their healthy peers. Parents are often really overprotective. They find it difficult to move on from the past. And that can cause some conflict with the child survivor who wants to really get on with their life. So in conclusion, surveillance for and management of late endocrine effects is complex. Those most at risk of endocrinopathies are those with a history of bone marrow transplant, treatment with radiotherapy for any cancer, or treatment with alkylating agents. And the endocrine effects of newer agents, such as TKIs, is still being explored. There's much more consensus globally about our approach to surveillance and the management of late effects. And ideally, we want a dedicated clinical late effects service. We've also got many other systems, as we've mentioned, also affected by late effects of cancer treatment. And one of the most important effects is second malignancies, very sadly. That's all I have to say. Thank you very much for your attention, and I'm happy to take any questions.
Thank you, and Debbie, for that good and clear presentation that you have done. I have seen a few questions that are there in the group. Some of them I have answered them for the people who have asked the question. There are many people who are asking about CPD points that will be covered later, and we should check with the Kenyatta team. Maybe they will tell us later about the CPD points. Debbie, I see you have removed the presentation, but I wanted you to take through the growth chart, just with an ordinary growth chart. You see how
Just what, sorry?
With an ordinary growth chart to show how we can pick the patient with thyroid deficiency, growth hormone deficiency, and even sex hormone deficiency. There is a growth curve you had at the beginning.
Yes, I did. I'll see. You won't be able to see my slides, though, will you?
If you can go back, you can still share your screen. Because with a growth chart, you are able to pick quite a number of the endocrine complications.
Yes, so I've got that, but I haven't, I've found that, but I haven't now got, let me just, oh, this does get complicated. This could take me a time. Oh, hang on, let me just have a look here. Nope, that's not helpful. Sorry. I will try, Lucy, but it may show presenter view. Let me just do that. I'm not doing very well here. I'm just going to end the slideshow. I think I better come back and join you properly. I'm not winning with that, Lucy. So
okay, I think it's okay. The only thing you can just mention about with the growth curve, even if you don't have it, how you can use a growth curve to show that the patient doesn't have growth hormone, does not have thyroid hormone, does not have sex hormone.
So you can't, you're using it in just the same way, all right, as you would for any growth chart, all right? So you're monitoring the growth of that child, and if they start to deviate from that centile, and you're keeping where they are in puberty, if they're of that sort of age, if they're peripubertal age, if you're keeping that in mind as well, then it's really when they're crossing down centile lines. So when they start to cross, obviously it depends on how many centiles lines you have, but crossing down centile lines. So they're, you're seeing that growth chart, then really just not growing as they should do. They've got, and if you can measure their height velocity, so you're looking at you obviously need to do, you need to have decimals of your years so you can work out your height velocity per year, then you can look at their height velocity and compare that with standard charts as well. So there's no difference with diagnosing their growth hormone deficiency or their thyroid hormone problems as there is for any other child, which is why I haven't gone into these in great detail, because obviously otherwise it's the management of every sort of hormone deficiency. And it's really to highlight where things would be different. And as I say, the difference here is that you wouldn't see, in those who've had TBI, you wouldn't see an effect of your growth hormone replacement necessarily. Sometimes you will, but not necessarily.
There is a question here asking about the side effect of replacing estrogen in patients who require estrogen replacement therapy. Is there any risk of replacing estrogen in children who don't have it?
The benefits of it far outweigh the risks. So giving estrogen in the doses that we're talking about, just replacement, all right, there is a more of this is related actually to the progestogen. So you obviously need both once you're on full hormone replacement, but they give an increased risk of venous thromboembolism and stroke, all right? So, but in a young woman, all right, that risk is tiny. And if it doubles, it's still tiny. So really the risk of estrogen replacement in young women, 30s, 40s, the recommendation is that they're replaced up to the age of natural menopause is very minimal, and the benefits far outweigh. So we're talking of maintaining your bone mineral density. We're talking about the effects of cardiovascular health. We're talking about the effects of maintaining your secondary sexual characteristics, of maintaining good uterine health, so good skin, hair, so many positive effects. Are there any risks? Really, very, very few. And the problem is confounded by very large-scale studies of the use of HRT, so hormone replacement, in postmenopausal women. They are a totally different group of individuals. So in postmenopausal women, you're replacing estrogen in those who naturally wouldn't be seeing estrogen anymore. And therefore the side effects, the risks that you may see, so increased risk of stroke, increased risk of cancer, does not particularly apply to this group. Having said that, increased risk of cancer, as soon as you add in sex steroid, then you're increasing your risk of sex steroid responsive tumors, but the risk is still small. You have to ignore some of that research in postmenopausal women. Even that has been refined to it's perfectly satisfactory to continue with, if you come to the end of your normal reproductive life, then starting estrogen replacement straight away is beneficial. It's really if you stop it and then start several years later that there are more side effects. I hope I've answered your question.
Thank you, Debbie. Is there any treatment for a boy who is 15, 16 years when you realize they are not producing sperms? Is there any treatment for that? Somebody is asking.
That's what I'm saying. There isn't. Not if they're not producing sperm that way. That's why. No, there isn't. So that's so if that boy has had their treatment, the big thing is if he had gone through puberty at the time of his treatment, then some boys are able to produce a sperm sample, or you can take some testicular tissue and retrieve sperm from them. But if he was prepubertal at the time of his treatment, then he would have had to have had some testicular tissue removed at that stage, and nobody would do that really because there is no evidence that can successfully be allowed to produce sperm. So it's only on a research basis. I mean, there is progress being made. So just in the way that for females, you can take ovary pre-treatment and store it. You can't yet for males. That technology isn't there. But for that 16-year-old who's gone through treatment, who doesn't produce sperm, I'm sorry, but no, there isn't any treatment for that. They will be infertile, all right? But because the two things are separate, if their Leydig cells have, if the cancer treatment has not been too aggressive, then they may well be able to produce testosterone normally, even though they can't produce sperm. So they don't need replacement, but you can't replace the sperm.
Somebody is asking, can the pediatric endocrinologist be involved early in the treatment of these patients by checking these hormones early and then help with the titration of the chemotherapy so that the drugs can be reduced so that the child doesn't become worse?
I think that's a really important point, and I think it's not really the endocrinologist's role to speak to our expert oncologists on how these patients should be treated, but this is done much more on a larger scale with clinical trials. So I mentioned before, so when giving cranial radiation was standard for treatment with acute lymphoblastic leukemia, all right, which caused a lot of issues, so growth hormone deficiency, not infertility at that stage, but because of the problems there, there was a trial done to see if omitting 18 gray of cranial radiotherapy in uncomplicated cases would allow the same survival rates. That went through, so the cranial radiotherapy was stopped. In those with relapsed acute lymphoblastic leukemia, who then go on to have a bone marrow transplantation, they also look to see, could we do this without giving the TBI at the time of conditioning? So you largely remove your bone marrow with the high dose cyclophosphamide. And if you remove the TBI, could you protect them from complete infertility or lack of spermatogenesis, lack of ovarian function? And what they found, it was only a small trial, but what they found was that the patient started to relapse. So these late effects, you can see some of them. I mean, I think the bone marrow transplant survivors are the most affected by late effects. And you can see that this group that I'm talking about have got so many things to deal with. That's not the case routinely. And what if you were to ask a patient, well, we could, modify your treatment so that you may not survive, but if you do survive, you've got a greater chance of maintaining your fertility. I would suggest to you that nearly everybody, 99% will say, I'll go for survival. And we do, there is always counselling about the risk of infertility. And really, it's not a priority at that time. A lot of patients have even forgotten, and their families have forgotten that discussion ever existed, because they're terrified. They've got cancer, they've got a life-threatening illness, and they're just a child. So it's not the major priority at that stage. And yes, we wouldn't intervene at all with our 2 Pennyworth.
There is somebody here who has asked a question, which somebody is asking whether if a young girl, if she has undergone hysterectomy, you have sexual desires. Sexual desire does not come from the uterus. It is actually some activity related to the hormones from the pituitary and the ovaries, not the uterus. And I don't know how this young girl would have gone through hysterectomy at that young age. Sorry,
I don't understand. What is the question?
No, there's another question. Just listen to me, Debbie.
Yeah.
There is a question that has been asked here because you gave us an example of Sally. Sally, the small girl who had AML and had a total body irradiation. And she had 14.4 grays or total body irradiation and
Yep.
chemotherapy, and then bone marrow transplant.
Mm-hmm.
So the question is, why does this girl have all these complications and the radiotherapy was not as high as the figures that you have quoted of 18 grays?
Well, in terms of her primary ovarian insufficiency, she also had cyclophosphamide high dose as conditioning. And in fact, so that would be enough to render her, with primary ovarian insufficiency and not to go through puberty. Although some patients do sort of sneak through that, but the two together are particularly gonadotoxic. Having said that, one of our survivors who had a live birth, she also had acute myeloid leukemia, and she was older when she developed it, and the treatment protocol had changed. So she had a bone marrow transplant as soon as she'd gone into remission. There was no waiting for her to relapse. So she only had her initial chemotherapy and then her bone marrow transplant with the conditioning. And although you might have expected her to have primary ovarian insufficiency, she had elevated gonadotrophins, but she went through puberty spontaneously. She had some problems really with sort of menstrual irregularity, I think related to the fact that she had some ovarian insufficiency. And she at that time went on to a contraceptive pill called Clara, which uses natural 17-beta estradiol instead of ethinyl estradiol. She came off that. She got married, she got a partner, and she conceived, and she's had a live-born baby. So these are not, you can't always predict what's going to happen. And there is some suggestion it's low quality evidence that the TBI, even though you're only giving 14.4 gray, it seems to have more effect than a localized radiotherapy dose. So 18 gray for growth hormone deficiency if you just had your pituitary irradiated, but there's certainly a lot of descriptions in papers of patients who just had TBI who then had growth hormone deficiency. So,
and now we are going to ask you the final questions. The final question now. I would like you to explain the relationship between the replacement of thyroid hormone, cortisol, and growth hormone, and why you usually have to give cortisol early.
Why you have to give it early? Well, you don't in this group generally.
I'm saying if a patient has you don't know
if you have all of those deficient.
Yes.
Yeah. Okay. Well, because for the thyroid, well, really for both of them, they both work in not dissimilar ways. So the thyroid in particular, you're suddenly increasing your basal metabolic rate, you're increasing turnover, you're increasing demand, really. So if you're already adrenal insufficient, then the effect on cortisol clearance, so you're increasing your clearance of cortisol, so you've got less cortisol available, then you can precipitate an adrenal crisis. And it's a very similar effect for growth hormone. And in most cases, because they haven't had treatment that's toxic for the ACTH, the basophils in the anterior pituitary, then it's not a major concern. And obviously your primary thyroid dysfunction, if they've never had an issue with adrenal function doesn't, primary adrenal function really is going to be affected by adrenalectomy. And certainly under my care, I have a couple of patients who've had bilateral adrenalectomies for treatment for their neuroblastoma. So therefore, obviously, we're giving them full adrenal replacement. So, and another one was a girl with a unilateral adrenal tumor, which was producing cortisol, androgens, and she, because it was producing cortisol and was removed, the other adrenal had been suppressed because she'd had this tumor for some time, and that suppression persisted for a good year or more. So yeah, that's the sort of situation in which a primary adrenal insufficiency may arise, and those arising from ACTH deficiency, you need to, it's quite, you're either going to have everything affected, such as in craniopharyngioma, or you've got radiotherapy, in which case the ACTH producing cells are very radio resistant.
Thank you very much, Debbie. You have done a great job. You have answered our questions, and your presentation was very, very clear. There are just a few things I would like to answer. There are some people who are asking about CPD points, and they say they are looking for this presentation from the Pharmacy and Poison Board. This presentation is not from the board, it's from the Kenyatta Hospital and the University of Nairobi website. So you get it from the KNH website, where you get the resource center. If you go online, you go to the resource center, that's where you are going to check for these slides, but they are not there now. They will be put there later. And we are not going to send you by your email. That's where you're going to get them. We had about over 1,600 people in the group. So we will not be able to send you one by one, but you can check them in the website of KNH. And about CPD points, they are supposed using the email that you have sent. And the problem is, if you have written that you are anonymous, so it is very hard for people to know who to send the CPD points, and you have written you are anonymous. So we usually encourage people to use their names than just to leave it as anonymous. So they are using the email that you have sent. That's where they are going to send you your CPD points, using the email that you registered with. And with that, I think I'll hand over to the KNH team. I don't know whether Amoro, you are there, so that you can ask us anything about CPD points. And for now, I think from our side, Debbie, thank you very much. We don't take it for granted.
Well, thank you very much for listening.
Yeah,
thank you.
Listen to us. Thank you, everybody. Amoro, are you there? Dr. Priska Amoro?